Yes,
So,
sir.
so this is a case of varicose veins. So with relation to this case, can you tell me the significance of age, gender, and occupation in your case?
Yes, sir. AIDS, it is more common in elderly age, sir. And gender, it is more common in female than male. And occupation, sir, the occupation which demands like long time standing. So it is very
Why?
susceptible.
Why is it so? Can't we see the varicose vein in younger population?
Yes, sir. In younger population also it is there, but in elder it is more common.
What about the gender? Why it's more common in ladies?
In female, it is more common due to, sir, in female hormonal is there. This one progesterone is there. Because of that, it is more common in females.
Okay. So occupation, how does it related?
The patients are here. My patient is a worker in chimney factory. Like he used to climb in the chimney and used to clean the things on top of the chimney, sir. So, long
No,
term,
how this occupation is related in causing varicose veins? I'm asking.
so because of long standing, so venous pooling is there,
Okay.
and it leads to chronic venous hypertension.
Okay. Good. So what are the common chief complaints with which a patient presents to you in case of varicose veins? What are the possible symptoms?
First of all, sir, it is dilated tortuous veins or swelling in the lower limb. Then pain might be there, like dull type or dragging type of pain. Then its complications like hyperpigmentation or edema or itching over the limb, like that. Main,
So yeah,
main
mostly they are
complaint is,
asymptomatic. Okay, mostly these varicose veins patients are asymptomatic, but then they can present to you with slowly in a later stage with the pain. Okay, what are the causes for pain, or what all types of pain we get in varicose vein patients?
it is dull type pain or dragging type pain. And the
Okay,
pain is due to, like in case of venous hypertension, the vein overstretched, stretching of vein and the hypoxia in layer of tunica media. And it also compresses the somatic nerve near that. So,
okay. It's a very severe pain. Okay, they are coming with night cramps and severe bursting type of pain. What do you suspect?
DVT, sir.
Okay. Then what other cause of pain? One is venous chronic venous hypertension, whatever you told. Second thing could be because of secondary infections. Okay, all like thrombophlebitis or the ulcer secondly got infected. All this can cause pain. Third thing, it could be because of deep vein thrombosis. Good. So what are other symptoms?
The symptoms, sir, edema may be there. Then,
Edema. Okay, again because of venous congestion.
yes, sir.
Okay, which increases over period of the like by evening. It more in the evening time. Okay, after all the like whole day standing or working, by evening they observe edema around the ankle. And then see, edema, is it important? Like what kind of edema? Will give you any
Edema,
clue?
sir, it is not, mostly it is a non-pitting edema, sir.
Okay, no, that's on examination.
Yes.
Edema, you have to further evaluate whether it is only around the ankle or it
Mostly
involves whole of the leg.
in Gators area, sir, because of high hydrostatic pressure in that area.
So if it's localized edema, okay, if it's localized edema around the ankle, that means it's mainly because of the venous congestion, okay, venous pooling, okay, or also it could be that also can give you a clue for etiology. What is that?
Any obstructions or obstructive etiology?
Likely, have you heard about AV malformation?
Yes, sir.
That can be like bulge or local gigantism may be there. That can be seen as a swelling. That can also lead to secondary varicose veins. If
Yes, sir.
the edema is involved whole of the limb, lower limb, that means the varicose veins now has developed DVT, deep vein thrombosis. In which there will be the entire the leg will be involved, edematous. Okay, so extent of the edema is also important, and then they can come with some complications like ulcer
Yes,
and
sir.
the bleeding, pigmentation, and other things. We will discuss. Okay, next slide, please.
Yes.
Okay,
Yes.
so he's having since 8 years. Okay,
Yes.
now he's having no pain, right? Only
Yes, sir.
uh,
No pain.
dilated veins are there, and not associated with any pain. Or why did you ask about this night cramp?
Sir, to rule out the DVT, sir.
Okay, then this is very common in even without DVT also. This that bursting type of pain. Okay, it's very common in varicose veins, especially during the night time. Okay, so you should ask for that. Next. Okay, this is again this history. You should not get misguided. Okay, all these varicose veins patients or diabetic foot patients, they will have any kind of some kind of trivial traumas. Okay, trivial traumas after following which they develop a small ulcer. Okay, yeah, and it could be it may be non-healing. Okay, because of this venous insufficiency. So where do we commonly see the ulcer in case of varicose veins?
Yes, sir.
Where do we commonly see the ulcer in the case of varicose veins?
Mostly, sir, in Gators zone, like around the medial malleolus.
Okay, that depends on the which vein is involved. Okay, if it is in the course of the great saphenous vein, it could be mainly seen on, around the medial malleolus. Okay, if it is in the short saphenous vein, then it's mainly on the lateral aspect of the leg. Okay,
Yes, yes.
so next slide. Okay, can you please tell me the reasons why you asked all these questions?
Sir, no history of, no, sir, night cramp history has to rule out DVT. Then pain, no history of pain while walking. That I have asked to rule out any if arterial disease is there, sir. Then fever,
Why
breathlessness.
you are doubtful about the arterial diseases here?
Because of, sir, ulcer, I thought like
Okay,
arterial
when it's
also might.
ulcer, then anything else?
No, sir.
Any comorbidities he's having?
Yes, sorry, sir. Hypertension is there. So,
And diabetic also.
diabetes also.
Diabetics, this atherosclerosis is okay, very
Yes,
common. So they can have multifactorial ulcers.
yes.
Okay, both arterial, venous, okay, even neuropathic. All three can combine together. Okay, so you have to rule out one by one. Arterial causes for the ulcer, venous causes, and the neuropathic causes. Okay,
Yes.
then why fever,
Then
breathlessness?
we have breathlessness, cough, and hemoptysis. Like the complication of DVT is pulmonary embolism. So to rule out that also. Then swelling, pigmentation, and itching. It is the complication of varicose vein. So that I have asked. Then abdominal pain, constipation, abdominal distension to rule out the any secondary causes of varicose vein, like abdominal malignancy and all. Then no history of prolonged immobilization. That is also a risk factor of DVT. So that's why I asked. Then no history of previous varicose surgeries. I was to rule out any if it is recurrent varicose case.
Okay, you have written so many things, but this has to be in an order. Okay, you can't write haphazard. Okay, even the symptoms, when you write, it should be the symptoms related to varicose veins. Okay, then symptoms are related to its complications, then symptoms related to its etiology. In that order
Yes.
only, you should write. Again, in the when you rule out something, first rule out the other symptoms. Okay, of venous system. Okay,
Yes.
varicose veins, any other symptoms are there, or you want to rule out the arterial system and the neural system, that you ask first. Then questions related to the complications. Once you confirm that it's a varicose, not arterial or the neuropathic, then you come to the complications
Yes.
related to the varicose vein. Then the related to the etiology. Okay, in that order. Okay,
Okay, sir.
not mix up. Clear?
Yes, sir.
Okay, next. You told KJ, you told long-standing causes varicose veins. Can long sitting can cause varicose veins? Sitting for long hours?
No, sir, I don't think so.
Huh? Why you don't think so?
Because like in
See, you
sitting
told us
position.
there. You know, you have already given a clue. Go to previous slide. No history of prolonged immobilization.
Yes, sir.
What will immobilization cause?
Immobilization causes lead to stasis of
Yeah.
blood in
So
the
sitting for long time,
but in
same no,
this.
same no. Even for sitting for long hours, okay, that can also predispose to DVT. Then it can secondarily cause varicose veins. Okay, it's
Okay,
called
sir.
E thrombosis. Those who are working in front of the computer and for
Yes,
long
sir.
hours, for continuously for days together, they
Yes,
can develop this something called E thrombosis. Okay, okay,
yes,
so they can also secondarily get varicose veins because of the obstruction of the deep venous system.
yes,
Clear? So
yes,
this
sir.
is also important.
Yes.
Next. Okay. So he's had a diabetic ulcer gangrene of the right fourth toe. So he got amputated the toe, and he's also this you can write in the beginning. It's also okay in the HOPA also you can write at the end. Okay, he's
Yes,
a
sir.
known case of diabetes mellitus and hypertension for 7 years on regular medication. Okay, need
Yes, sir.
not be in past history because past is once cured is past.
Yes,
Okay,
sir.
but the comorbidities and still is having, so you can write it in the HOPA itself.
Okay, sir.
Next, yeah, family history.
Yes.
Why did you ask about the family history in case of varicose veins?
Like it can also be, sir, congenital varicose vein.
Okay,
Like
congenital. Okay, like what are the congenital
Fox2
conditions
gene
which can lead to?
mutation, then Klippel-Trenton syndrome, sir. Then Weber syndrome,
Park-Weber syndrome,
Weber
Klippel-Trenaunay
syndrome,
syndrome, then
Fox50
Kasaba-Merritt
gene
syndrome, all
mutation,
these syndromes. Okay, then
and connective tissue disorder might be there, like
okay, any connective
Marfan.
tissue disorders, very good. Then
Yes.
any particular gene, familial, which can
Fox2, sir.
very good. FOXC2 gene, this can predispose. Okay,
Yes.
these are the in the family. Yeah, even this could be familial. Most of the times we see. Okay, varicose veins running in the families. Very important.
Yes.
So next. Personal history, anything contributory in your case? Maybe, yeah.
Smoking,
Long
sir.
history of smoking is there. They cause this
Valve
connectivity to,
damage.
okay, that can predispose again. Good. Next, medication history is important. Okay,
Yes.
medication is history, especially in ladies. What you'll ask mainly the
OCT, sir.
OCPs, progesterone content can dilate the venous
Veins.
walls and cause varicose veins. Okay, then next. Okay, so what do you mean by varicose veins, KJ?
So it is dilated, elongated tortuous vein more than 3 millimeter in size.
It's not complete. Okay, yeah, your understanding is correct, but for a definition, so it's a permanently dilated. There could be sometimes in us also, physiological also, there could be vasodilation, right?
Yes, sir.
So it's any permanently dilated, elongated,
Tortuous
tortuous veins. Okay, rightly, like you said, it could be more than 3
3
millimeter.
millimeter in the.
Okay, and there is associated reflux of the blood mainly because of the incompetent valves.
Yes.
Is a complete definition.
Yes.
Okay, so usually varicose veins means we like it becomes synonymous with the varicose vein of the limbs, but
Yes.
varicose veins can occur in elsewhere also, like
In abdomen, sir. Lower part of abdomen.
sorry,
Lower part of abdomen, sir.
okay, what's that called?
Caput medusa.
Okay,
Yes.
then
Then esophageal varices.
very good.
Then hemorrhoids.
Wonderful.
Then bare area of liver.
Okay. Then in males, particularly
Varicose in this one, testicular, sir, testicular. Pempiliform
varicose veins.
plexus
Okay.
tortuosity.
Okay. Yeah. Similar. Many are there. Okay. In the retroperitoneum and even the vulval varicosities. All this. Okay. So, but
Yes.
most common thing is the varicose vein of the lower limbs. Okay. Because
Yes.
it's most common in the humans because of our erect posture, like you rightly mentioned in the beginning.
Yes.
So, okay. So in the history, our role, our main intention is to find the confirm that it's varicose vein, and secondly, to mainly in the history, we look for the etiological agents.
Yes.
Okay, what's
Yes.
causing these varicose veins? That's most important in case of history, and
Yes.
confirmation of the varicose veins, complication, everything will be done in the examination. In varicose veins, examination is very important. Okay, in
Yes.
history, we are looking forward for the etiological agents causing
Yes.
varicose veins. Clear?
Yes. Yes.
Okay. Please go to the. What are the etiological agents, by the way?
So it may be primary or
Three things. One is congenital,
yes,
or
congenital, primary,
primary, or
and secondary.
secondary. Congenital, what all it could be, as you told.
Yes,
Okay.
Park-Weber syndrome.
Okay. Some syndromes are there.
Then FOXC2 gene mutation
Okay. Then.
and connective tissue disorders.
Okay. Then. Okay. Then. Okay. Congenital. Then something called valveless avalvulia. Okay. Absence of the
Absence of valve in
valves. So
the
that
right
can also
segment.
cause. Okay. Then whatever the primary causes.
Yes, primary cause like if risk factor is there, if risk factor is present, sir, like
What kind of?
prolonged standing case is there,
Mhm.
and
Okay. Weakness of the valves or the vein. Okay. Muscle weakness can predispose to dilatation of the vein. Okay. Any primary etiology in the muscles or the vein or the valve.
yes, sir, yes, sir.
Okay. This is primary etiology. And what is the secondary etiology?
Secondary etiology is due to like any obstruction in abdomen, sir, or any pelvic area. Pelvic
Okay.
tumor is there,
Okay.
abdominal tumor is there.
Okay. Not just what to say obstruction. It could be obstruction or even the destruction.
Yes,
Obstruction, like you said, in the say again, wherever the pressure putting over the great veins, like even the pregnancy, okay, any uh,
yes,
mass in the abdomen, even in the retroperitoneum, okay, or even the obstruction like iliac vein or thrombosis, femoral vein thrombosis, all this can this thing, okay, and some destruction of the valves by the
yes,
DVT because of this prolonged immobilization, okay, and surgeries, okay, traumatic, all this can cause, okay, and even sometimes uh, long standing occupational also can be considered as secondary etiology, okay.
yes,
So
okay.
these are the etiological causes. So in your case it would be most probably occupational, right?
Yes, sir, might be.
Occupational, no other etiological factors found.
Yes, yes. Cigarette smoking was there, sir.
Okay, it's a contributory, okay,
Yes,
fine.
yes,
Next, examination.
yes. General physical examination, consent was taken, examination was done in well-lit room and privacy was maintained. Patient is alert, cooperative, well oriented to time, place, and person. Patient is moderately built and moderately nourished. Height 165 centimeter, weight 54 kg, BMI 19.85. Vitals: pulse 75 beats per minute, regular rhythm, good volume, normal character, no radial and radiofemoral delay, and all peripheral arterial pulses felt. Blood pressure 130 by 80 mmHg in left arm in sitting position. Respiratory rate 16 breaths per minute. Temperature, he was afebrile at the time of examination. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema absent. Local examination. Patient was examined in standing and supine position with both legs exposed up to umbilicus. So inspection. Attitude of limb normal. Localized dilated veins noted over the anterior medial aspect of left lower limb from 15 centimeter below the knee joint up to lower one third of medial aspect of thigh. And there are two ulcers present on the left leg. First was approx 3-5 centimeter in size with sloping edge, a well-defined regular margin. Floor covered with slope is present approx 4 centimeter above and anterior to medial malleolus. And the second was approximately 2-3 centimeter in size with sloping edge, well-defined regular margin, and floor covered with slope, and is present approx 3 centimeter above and posterior to medial malleolus. Skin color and texture appears normal. No loss of hair, dryness of skin, trophic blanches, no loss of subcutaneous fat, no saphenaverics, no edema, no visible veins over abdomen. Then Morris's cough test is negative, and right lower limb appears to be normal except fourth toe, which appears to be missing. Palpation, no local rise of temperature and edema, tenderness present over the ulcer. All inspectory findings confirmed. Regional lymph node palpable. All peripheral arterial pulse felt. Sensation and proprioception is not disturbed. Then ulcer examination, two ulcer, first 3-5 centimeter in size, sloping edge, well-defined regular margin, and muscle felt at base and floor covered with slub. Is present 4 centimeter above anterior to medial malleolus. Some bleeding are seen over the ulcer. And the second ulcer was 2-3 centimeter in size with sloping edge, a well-defined regular margin, muscle tendon felt at base and floor covered with slub. Is present 3 centimeter above and posterior to medial malleolus. Then tests. Brody Trendelmark test, test 1 negative and test 2 is positive. Tourniquet test positive, indicating incompetence of above knee, below knee, and above ankle perforator. Swab test positive. Morris's cough impulse, no impulse felt over saphenofemoral junction. Then Fagan's method, depressions felt at above knee, below knee, and above ankle perforator sites. Pratt test and modified Perthes test is not done. Percussion, swab sign positive. Auscultation, no brute heard. Systemic examination, per abdomen, no distension, no palpable mass, no visible scar and engorged veins. Bowel sounds heard. Respiratory system, bilateral, normal vesicular sound heard, and no added sound. Cardiovascular system, S1, S2 heard, no murmur. CNS, no focal neurological deficit. So, my provisional diagnosis is varicose vein in left leg involving great saphenous vein and lower limb perforators incompetence of primary etiology, C6 EP etiology primary, and anatomy superficial and perforators, and pathology reflux with complication.
Okay. Can you go back to the local examination?
Yes.
Okay. In local exam inspection, mainly we are looking for three things. Okay. One is which system of veins is involved. First thing, by looking only, by inspection only, we can make out which system of veins, that is in superficial, whether great saphenous vein or short saphenous. How do we make out?
Yes, sir. Great saphenous vein was involved. Like anatomically, you have seen in medial side of the leg, anterior medial aspect of left lower limb is involved.
Okay. Short saphenous?
Short saphenous are lateral and posterior.
Okay, so that's the first thing, which vein is involved. Second thing is we have to comment about the edema.
Yes.
Okay, edema. So edema, like we already discussed, that edema could be localized or generalized in the limb. Okay, yes. Localized because of two things. Okay, one is venous congestion. Second thing, like here, see, localized dilated veins are there. The entire vein is not dilated.
Yes.
Right. The entire course of vein is not dilated. Only the localized dilated veins are there. That gives you a clue that itself will give you a clue that what varicose veins is because of
some primary origin, sir.
Not about primary or secondary. What kind of incompetence?
Perforator incompetence.
Okay. If there was a incompetence of the saphenofemoral or saphenopopliteal junction, entire vein course would have been involved or dilated. Yes. Correct?
Yes.
Only
Yes,
there is a localized dilation of the veins are there. That means that most probably perforators are involved. Okay, wherever there is perforator incompetence is there, that area is mainly dilated. Okay, that's again the clue. Okay, so that is about the swelling. That's a localized or the generalized swelling is there. Generalized
Yes.
swelling can be seen in DVT. Okay,
Yes.
deep vein thrombosis. Then coming to the skin changes. What are the skin changes we observe in varicose veins?
Skin changes, sir. It started at telangiectasia, sir, reticular vein, then varicose vein, and then we'll have itching, edema, hyperpigmentation.
Why?
Then
Hypo?
hyper, sir, hyperpigmentation.
Why? Why all this?
So hemocytin deposition, like
Okay. Why that theory is and all we should know. Okay, why all
yes,
this happens? That's all theory questions that will be asked in the theory. What are the fibrin cuff theory, white cell trapping
yes, the white cell
theory,
trapping theory.
ambulatory venous hypertension theory? All these things we should know. Okay,
Yes.
and so because of the hemocytin deposition, there is hyperpigmentation, eczema, other things.
Yes.
Okay, so then what other skin changes can you observe?
Then lipodermal then whitish patch, sir.
What is
Corona phlebitis. Corona phlebitis.
Sorry.
Corona phlebitis, sir. Whitish patch.
Okay.
Then ulcer, sir, finally.
What is lipodermatosclerosis? You told.
Okay, sir. Lipodermatosclerosis, sir, it is due to this one fibrin deposition, sir. In gaiters don't become thick, like skin become thick, sir.
That's because of the scarring. Okay.
Scarring, sir. Yes.
Tissue death, scarring will result in the thickening of the skin. That's called lipodermatosclerosis. Okay.
Yes.
Then you are telling some there is phlegmasia alba dolens and phlegmasia alba ceruleans. What are these?
Yes. These are, sir, like whitish and reddish patches over the gaiters joints.
White leg and blue leg, not the only gaiter zone, the entire leg. Edematous. Why? Because why it happens? Phlegmasia alba dolens. You know the reasons, and how do you differentiate?
No, sir.
Please read. Okay. Phlegmasia alba dolens and phlegmasia cerulea dolens. It's mainly deep vein thrombus in the femoral veins and the iliac veins. Okay. When the femoral veins are involved, and along with the lymphangitis, even the lymphatics also get blocked. That cause that very edema of the lower limb, resulting in the whitish pale leg. That's called phlegmasia alba dolens. When the higher up, when the iliac or veins are obstructed, okay, it can cause the severe edema and tightening of the legs, along with the gangrenous features of the that's called venous gangrene. That's called phlegmasia cerulea dolens. Cerulea means blue, alba means white. Okay, how do we differentiate other than the color? Is palpate for the pulse, distal pulses. In alba dolens, pulses are palpable, whereas in cerulea dolens you cannot palpate the because it's the gangrenous. Okay, so the pulses may not be palpable. Okay, that's how we differentiate. Clear?
Okay,
these are the complications. And okay, so these are the skin changes we note. Okay, so in inspection, clear? No, first we look at the which vein is involved, then look for the edema, then the skin changes, and of course the ulcer. Attitude of the limb. Why it's important?
Like in chronic case, patient use the like toe to walk. So, like,
sorry,
sir, patient use in chronic conditions, sir. Like
what happens?
Patient use, sir, for walking, he use the toe, sir.
Like okay, why?
Equinus.
Pain gets relieved. Okay.
Yes,
on walking on the toes.
To decrease the pressure on the calf muscle.
Okay, then what happens?
So it leads to like equinus deformity.
Shortening of the tendons that leads to equinus deformity. Okay, yes. So attitude is important. Oh, there is already bony deformity is there or not? Wait and R you press. Okay. Next, localized dilated veins noted over the anteromedial aspect of the left lower limb. Okay, so that means mainly the great saphenous vein is involved. Okay, that gives a clue. Okay, yes. Then It is a localized dilated veins, so it could be because of perforator incompetence. So on inspection, we got a clue. Next. Okay, ulcers. You described the ulcers. Uh, Pretty okay. Okay. So the margins could be well defined or ill defined. Okay.
Yes.
The well defined, it could be either again regular or irregular
Irregular.
margins. Okay. Floor is covered with usually slough. That means it's infected, secondarily infected.
Yes, sir.
Okay.
Yes, sir.
Okay. So okay. Then the edge. Have you mentioned about the edge?
Yes, sir.
Sloping edge. Okay, edge you mentioned. Okay. Okay, fine. This is fine. Next. Okay. Skin color and the texture. Why did you particularly mention about the texture?
Sir, like it's complications of varicose vein complication in
Like,
lipodermal sclerosis.
okay, the thickening you can feel. Okay, that texture. Okay. Then anything like in a or gangrenous stage or any other skin changes texture you can know.
No, sir.
Shiny
Skin
or
becomes
shiny skin,
loss of hair.
loss of hair.
Yes,
Very
sir.
good. Brittleness, all these are very good. Very good. Oh, you're written next. Okay, no loss of hair, drain of
Yes.
skin or atrophic blanches. Okay.
Yes.
Okay, no loss of subcutaneous fat. What is that?
It is also to rule out, sir, arterial disease. I guess.
Okay, fine. No saphena varix. Why did you bring out saphena varix here?
Like no dilation was there at
Saphena varix, where does it occur?
at junctions, saphenofemoral junction.
Okay, no, anyway, not required here. No edema. Okay, no visible uh, veins over the abdomen. What is Morris's cuff test? How do you do that?
Sir, Morris's cuff test we can do in inspection and palpation both, sir. And in this, we ask first we place the patient in supine position, and then we like milk the vein, like we will empty the vein, and press by thumb, or we'll ask the patient to cough forcibly, and we'll check at the saphenofemoral junction if any pulsation is there.
Expansile cough impulse. This could be visible. Okay, expansile type again, just like hernia. Okay.
Yes, sir.
Okay, fine. Next. Okay, palpation. Okay. Okay. If there is a tenderness, what does that suggest? There is a local rise of temperature and tenderness.
So it suggests like inflammatory process is going on. Ulcer.
What's that called? Should be specific. Inflammation of the vein. What's that called?
Thrombophlebitis.
Superficial thrombophlebitis. Okay. Yes. That can also be a cause for a pain and tenderness. Okay. Yes. Local rise of temperature. Okay. Any other cause can lead to local rise of tenderness, temperature, related to bone. So ulcer is there.
Osteomyelitis is there.
Not osteomyelitis. Before that.
Tendon infections or tendinitis.
No. Have you heard periostitis?
Yes, sir. Periostitis.
Yeah. Periostitis is common. Underlying with ulcers. Okay. Again, common complications. So that can also tenderness, local rise of temperature. So mainly we see before you're examining, you should have something in the mind why you are doing that. Correct. Yes. So if you know all those things in the back of the mind, then you can specifically look for all these things, or just generally like you will be doing something. Okay. Clear?
Yes, sir. Clear.
Okay. Regional lymph nodes palpable. I don't know what is the regional lymph node here.
Sir, inguinal lymph node. Sir.
In particularly
right left-sided inguinal lymph nodes. Sir.
Vertical group of lymph nodes. Okay, and even the iliac. Where you palpated?
In this inguinal region, sir, below inguinal ligaments.
Below or above?
For this one, inguinal lymph node below. For iliac, it is above.
Okay. So all peripheral arterial pulses are felt. Okay. So you wanted to rule out any other peripheral vascular disease. Okay.
Yes.
So any no neurological disturbances also. Clear?
Yes. Yes,
So
yes.
very important, especially in a chronic diabetic. They can, as I mentioned earlier, they can have
Yes.
multifactorial diseases. Okay, even the additional neurological and arterial disease can also be there. So we have to rule out these first. Okay, next.
Yes, sir.
Okay, ulcer examination is okay, pretty okay here. Uh, okay, we will discuss in separate ulcer case presentation. What are the things to be? Almost you written everything clearly. Okay, next. Okay, now tell me more about this test, because in a varicose veins examination, mainly you will be asked questions on these tests only. Some
Yes.
special tests are there. At least you should know the inferences, how to do the test, and what is the inference. Can you please tell me
First, sir, broadly Trendelenburg test one
mainly why
is
you do for that test and what's the inference you tell me? How to do
yes,
and not required.
yes. Sir. Test one we do to check the incompetence of saphenofemoral junction, saphenofemoral valve, sir.
Okay.
In this patient, we place patient in supine position and we empty the vein and then press at saphenofemoral junction, or we can use the tourniquet, sir. And then we ask the patient to stand up quickly, and then we release the pressure. If the filling of blood from above, it is like very quick filling, then it is incompetent saphenofemoral
Very
valve.
good. Very good.
And, so, but it was a negative. And then test two, in this test we don't release pressure immediately, sir. We wait for 1 minute, and then we
Ask
look
him.
for the venous filling from below upwards, sir.
Meanwhile, we ask him to walk around. Okay.
Yes, sir.
You ask him to walk.
Okay, sir.
Then after 1 minute, you release the pressure. Then
We look for the this one venous filling, sir, blood filling in the lower legs, sir. So if it
that's
is below upward, then it is perforator incompetence.
okay. So multiple tourniquet test.
Yes, sir. Tourniquet test also we use to assess the perforator incompetence. So in this we can use 3 or 4 tourniquets, sir, at different level after emptying the veins, and then we make the patient standing position, and then we look for the filling of the blood in different areas, sir. So if the above the tourniquet that blood is getting filled, so that means that perforator incompetence is there. Or if below it is getting filled, so below perforator get incompetence is there.
Okay. What is that Schwartz test?
SWOT test is just to do like if any blood column is there, like valve is absent, sir. So SWOT test was positive. We pulse, see, we tap the varicose veins on lower side, and we check if it is filled at upper saphenofemoral junction or any other side.
Okay. Next, Morris's cuff impulse.
Maurice's cuff impulse, like no, this one is also for saphenofemoral junction incompetence, sir. So we first emptying the vein, and then ask the this one patient to cough forcefully, and we check the saphenofemoral junction if any pulsation is there, extensile pulsation is there.
Okay. Next.
Fagan's method, this one for also this one for perforator incompetence. In this, we do like first in standing position, we mark the blowouts, and then place the patient in supine position in emptying the vein, and we palpate the marked positions, the marked site, and we can feel the depressions in that blowout areas.
Okay. Modified Perthes. What's Pratt's test? Why it's not done? Very good. I thought that you will write that also. Okay. Usually they do that mistake in the examination. They blindly write all the tests, and then they realize when the examiner asks that how did you do the Pratt's test, then they will realize, okay, that Then they'll tell that also. I put the bandage and everything. Then the exam will ask, from where did you get this S-marked bandage? Then
Yes,
they'll
sir.
get caught. So don't do that. Again, Fagan's test also, that is followed by this Pratt's test. You first do the Pratt's test and mark the blowouts. Okay.
Yes, sir.
Then in the Fagan's test, look for the depressions in that area. Okay.
Okay, okay, sir.
Okay. Then see, I'll tell you, you have done pretty well all the tests and you know the theory behind it. But to remember better, okay, we can classify these special tests into 3 categories. One, to look for any incompetence, saphenofemoral or saphenopopliteal incompetence. Okay, there are 2 tests for that. What are those?
Broadly Trendelenburg type 1, sir.
One, and another one is Morris's cough impulse.
Morris's cough impulse test.
These
Yes.
2 are for incompetence.
Yes.
What saphenofemoral, saphenopopliteal. Second comes for the perforator incompetence.
Yes, sir.
There are 4 tests. What are those?
Tourniquet test, broadly Trendelenburg test type 2.
2, multiple Tourniquet, Pratt's test, and then comes the Fagan's test.
Fagan's test.
There are 4 tests. Okay,
Yes.
for the perforator incompetence. Then comes to the to know the rule out DVT.
Yes, sir.
There are again 4 tests for DVT.
Yes.
Can you
Perthes test, modified Perthes test.
Okay, Perthes, modified Perthes,
Homans and Moses.
Homans and Moses.
Yes.
If you don't do also fine, like how you mentioned, that's okay. But you should know.
Moses, we can't do.
Can I ask you how modified Perthes is better than the Perthes?
In the modified Perthes, sir, we don't empty the veins, sir. No.
If you know what is Perthes, what is modified Perthes, then you may differentiate. See, in Perthes, they'll only complain of pain, right?
Yes.
On walking, they'll complain of pain. So it's pain is more of subjective, right? Pain is more of subjective. Some people may get pain, some may not. Yes. Okay, so we can't completely rule out DVT. But modified Perthes, along with the pain, we can also see the prominent veins, superficial veins. So this is both subjective as well as objective.
Yes.
Right? So objective assessment, see, even edema, you said there is no edema, but I say there is edema. How do we confirm? How do we confirm?
Modified Perthes test.
No. I'm just simple question. You say there is no edema in the left leg. I say there is edema in the left leg. How do we confirm? There should be some objective assessment, right? All these are subjective. So there should be some objective assessment. How do we do that? By measuring.
Okay.
We can measure, right? On the right leg, which is normal leg, we can measure with that. Okay.
Yes, sir.
So there is any discrepancy, then we can say whether there is a edema or not. Some like that. Always try to find some objective assessment systems. Okay, to confirm your diagnosis. Clear what I meant?
Yes, sir.
So mainly 3 types of tests, mainly to rule out SFG or SPG incompetence, next perforated incompetence, then DVT. Okay, yes. Fine. Percussion, mainly you do the Schwartz. What is Schwartz sign?
Schwartz sign, sir, we tap on the this one varicose in lower part, and we can feel the pulsation on upper part or saphenofemoral junction, sir.
Okay. Then the auscultation. Why did you do the auscultation?
To rule out, sir, AV fistula, sir. AV.
Okay. What you will auscultate in AV malformation?
Like machinery murmur will be there.
Okay. Anything else? And auscultation? Venous hum. You know, venous hum.
Yes.
We can also okay. Also arteriovenous malformation at machinery murmur. You can. Okay. Next. Okay. Systemic examination. Mainly per abdomen examination is important here. Yes. Mainly to look for any. This thing. Have you? But something you missed before this. Regional lymph nodes you are done. Arterial and neurovascular system you are done. Yes. Joints you are not done. Adjacent joints you should have done. Okay, not just the gait or the attitude. You should have done the adjacent joints. And the fourth most important which you have not done is the other limb. Have you examined the other limb? Right leg?
Yes, sir. I have written that, sir.
Where you written?
In inspection part only, sir. And palpation. Yes, sir.
Okay, right, lower limb appears to be normal. Okay, fine. Okay, again, the palpation also appears, okay, inspection were right, but on exam, like palpation, we don't know. Okay, so you can separately write the other limb, inspection on palpation for this thing, right limb also appears to be normal, you can write. Clear?
Yes, sir.
All this, because, yeah, I'm not pinpointing yours, but these are the common things should be done and usually missed.
Yes.
Varicose means we just tend to examine only the varicose veins, but no, it's not complete. Okay,
Yes.
we have to do the regional lymph nodes, especially when there is a ulcer. Okay, and second thing is adjacent joints, neurovascular system. Okay, and the other limb. These four things also very important. Okay, after that comes the per abdomen examination. Okay, good. Fine. Mainly respiratory system. Why? What's the relevance here?
The smoking history are there, sir.
Okay, one is that. Anything else?
Like if respiratory system will be affected, then intrathoracic pressure will be disturbed, sir.
Now, how can it get affected? That's what I'm asking. How varicose veins and respiratory system is related?
If it is related to, sir, DVT, then
What is it? Not directly related to DVT. Again, the complication of DVT. Again, what is that?
yes, a pulmonary embolism.
Yeah, pulmonary thromboembolism. Okay, be specific. Next. Okay, diagnosis you have written very well. Okay, these so always varicose vein diagnosis, just like hernia, we write under 6 headings, right? Similarly,
Yes.
in varicose veins also, it should be written under 6 headings. First thing is, first and foremost is whether it is primary or secondary. You are written at the end. That's okay. It's of primary etiology, weakness of the this thing, valves. Okay, incompetence of the valves. That's okay. Primary or secondary is the first point. Second thing is the great saphenous vein or the short saphenous vein. You already know included, no?
Yes, sir.
Involving the great saphenous vein. Second, next thing is the incompetence with or without saphenofemoral or saphenopopliteal incompetence. You have written that?
No, sir.
Yeah. Okay. That's okay. Saphenofemoral or saphenopopliteal incompetence should be written with or without. Fourth thing is the with or without perforator incompetence.
Yes, sir.
Okay. Here you have written with the
Yes, sir.
lower limb perforator incompetence. That's the fourth point. Fifth is the clinical signs. What is the clinical grade? You have written no C6.
Yes, sir.
That's the clinical grading.
Yes.
Can you quickly tell C0 to 6 clinical grading? Very important.
Yes, sir. C classification, sir. C means clinical, sir. C1 is telangiectasia. Then C2 varicose vein. Then C3 edema.
Very good.
Then C4A is lipodermal sclerosis, hyperpigmentation.
Skin changes. Skin changes, you write. Okay. C5 is?
Then C5 is healed ulcer, sir.
C6 is active ulcer. So this is why you have written C6. Yes. Okay, there is an active ulcer. So sixth point is, fifth is the clinical grading. Sixth one is the with or without any complications. So okay, these 6 points. Can you please repeat it for the benefit of others, KJ?
Yes, sir. C1, sir, telangiectasia.
No. 6 points under diagnosis. What all you should write? Okay,
sir. So first is location, sir.
Okay.
Then which vein is involved?
Okay, that's the first point. GSV or SSV. Okay. Next.
Yes, sir. Then if SFJ or saphenopopliteal is involved.
Very good.
Then if any perforator incompetence is there.
Very good.
Then with clinical sign, like clinical sign is there. And other then is complication, if any complication.
Okay, any complication there or not. Then sixth point is etiology.
Etiology.
Okay. It's primary or secondary. Okay. So these 6 points should be there. It's a complete diagnosis.
Yes.
Clear? Very nicely written. Very good. Okay. So next. Okay. Now the question will be, how do you manage this case?
Yes.
How do you manage this case?
First of all, sir, we'll do
A 70-year-old, remember, a 70-year-old gentleman with the left lower limb varicose veins,
Yes.
with two ulcers, okay, venous ulcers,
Yes.
okay, with diabetes mellitus and hypertension.
Yes.
How do you manage?
So first, we'll do, sir, investigation, sir.
Okay.
Like duplex scan, sir.
What is duplex scan?
So it is combination of Doppler and USG P scan.
What's the advantage over just Doppler scan?
Like in this scan, we can this one we can look for blood flow also, sir. Like if
In Doppler only you can see the functional, that's flow only. Venous
Yes.
or the arterial flow you can make out, any reflux is there. Whereas in the duplex, that is B-mode ultrasound also there, where you can
Yes.
see the anatomy also,
Anatomy also.
venous system also. So both anatomical as well as functional. Okay, that's why combination duplex. Then very good. Then
abdominal USG to rule out any other secondary causes.
okay, good.
And
Second, because
chest
elderly
X-ray.
man, no, yeah, there could be some abdominal pathology you want to rule out.
Yes.
Chest X-ray.
Chest X-ray, like he was smoker since long time, so
Okay.
rule out any cause. Then diabetic and hypertensive, so blood sugar and blood pressure, like we'll do.
Okay.
Then ECG, because like age and the risk factor is present in this patient. So we'll do ECG, and then blood grouping and RS typing, like if any blood he needs.
Okay. Any test you know for DVT?
DVT science is there, so
No. Any blood test to confirm?
Blood tests to confirm DVT.
Especially in pulmonary thromboembolism and all, we get it done.
That is CT scan only, sir.
No. Any blood test? Have you heard D-dimer test?
Yes, sir.
Fibrin degradation products test?
Yes.
Okay.
Yes.
These are the mainly to confirm. Almost varicose veins is almost clinical diagnosis. Okay, clinical diagnosis, but you get the scan done mainly to look for confirm your especially the incompetence, SFG or SPG incompetence and the perforator incompetence. Then with the USG you can mark the perforator site also.
Yes.
Sites you can mark. Okay, with the USG, and then to mainly look for any pathological factors like in the abdomen and other things. Okay, good. After that, how do you treat this patient?
Sir, for treatment, first compression stocking we can use. Then this surgical intervention needs.
So it could be either medical treatment or surgical treatment. Okay. Yes. What are the medical options available?
Medical options are like compression stocking, elevation of limb. And for ulcer, we can do Biscard regime, sir.
Yeah, first you have to treat the ulcer here, correct?
Yes.
First you have to treat the ulcer because two ulcers are there. So since for 1 month now, what is Biscard's regimen?
Biscard regimen, like we can use antibiotic, bandage, then
antibiotics only if it's secondary infected, not otherwise.
Biscard regimens are limb elevation and limb elevation, dressing, and compressions.
Compression is the most important thing. Okay. Yes. Compression. Then one more thing is exercise.
Exercise. Yes.
Active and passive exercises. Okay. Then the mainly the compression. Okay. Around 40 millimeter of mercury compression is required to this thing compress the superficial veins. Okay.
Yes.
That's important. Okay. Once the ulcer is healing. Okay. Once it starts healing, then we can go for the definitive treatment. What is that? Or the mainly the infection is not there. The ulcer is devoid of infection. Then we can go for the definitive treatment, because without removing the varicose veins, ulcer may not heal.
Yes. Yes.
Okay, so you have to do side by side. Okay, If
Yes.
because sometimes ulcer is very big, it will take long time to heal. Such that time you have to do the definitive treatment, as well as you can do the debridement and skin grafting for
Yes,
the
sir. Great.
ulcer also. Okay, very big ulcers. Okay, okay. What's the surgical options? Medical treatment? Yeah. Any other medical treatment? That's for Bisgard regimen for ulcer. For the varicose veins, what are the medical treatment options?
Sir, compression stocking we can use.
Okay, okay. That's more for prophylaxis. Okay, prophylaxis of the grade 1 asymptomatic uh, varicose veins stockings nowadays. Okay.
Yes.
Then any other medical uh,
We can use
treatment?
medicine to like decrease the venous hypertension.
Okay, very good, very good.
Then,
Then you know about sclerotherapy.
yes, sir. But it will
What's
come
the
in
indication
surgical.
for sclerotherapy?
Sclerotherapy we can use, sir. This Tessari technique we can use. Sir.
Sorry. Okay, technique is fine. What are the indications? Nowadays, only there are two
Indications, sir,
indications.
in
One is very
this one. First, telangiectasia, sir.
yeah.
And the second one is like if it is local perforator, recurrent local perforators. And
Okay, and mainly for recurrent varicose veins, recurrent varicosities, and the reticular veins.
Yes, sir.
Okay, these two are the indications for what is the contraindication for sclerotherapy?
Like if very long veins involved, very long.
There is incompetence, SFG incompetence is there. Ideally,
Yes,
it
sir.
should not be done. Okay,
Yes, sir.
clear?
Yes, sir.
Okay, next. After the medical therapy, what are the indications for surgery?
Yes. So surgery first if refractory to medical therapy or
Good.
if any complications is there,
Okay,
like in this case ulcer is there, so we'll do.
okay.
Then if this one cosmetic problem or if patient wants that.
Okay, mainly first thing is complaints. Is symptomatic and having complaints, which is refractory to medicine. Very good. Second thing is any complication. Thirdly, mainly for the cosmesis purpose. Okay, especially in ladies. Okay.
Yes.
Okay, good. So what surgery you want to do
Sir,
in this case?
tendon surgeries. Many surgery we can do, sir. Tendon surgery we can do, or
Why you want to do Trendelenburg here?
yes, here
Why
we
you
can
want
do,
to
sir.
do Trendelenburg here?
Yes,
Why?
to strip the sir great saphenous vein.
No. Here only there is. You only told no. There is no
Perforator, yes.
weapon of femoral incompetence not there. Only perforator incompetence is there. You only told
Yes.
no. So for
Yes, sir.
perforator incompetence, what we do? What surgery we do?
SEP, sir.
What is SEPS?
Subfacial perforator surgeries.
Subfacial
Perforator surgery.
ligation.
Yes.
Subfacial
Then,
endoscopic perforator ligation. That is okay. SEPS. Okay.
yes.
Okay. Or we just do stab avulsion of the perforators and just ligate it. Okay. So that's the one for perforator incompetence. We just ligate the perforator. We just mark just a stab avulsion, small incision we put over that perforator and we ligate the perforator. That's for perforator incompetence. If it involves the saphenofemoral incompetence or saphenopopulate incompetence, then we go for Trendelenburg operation. What is Trendelenburg operation?
Sir, in this operation, we tied at the saphenofemoral junction. And we use Mayer Kushner stripper and up to knee joints, and we strip the the vein involved.
Okay, good. Mainly, first thing is we have to ligate all the tributaries to the GSV. There are 3-4 named tributaries, right? You know,
yes.
anatomy.
Yes.
So all those things we have to ligate first, one by one. Okay. Then we do the flush ligation at the junction of the great saphenous vein to the femoral vein. That junction we ligate and we cut. So
Yes.
now GSV separated from the femoral vein. Now we put a stripper inside the vein, okay, which we till the just below the knee.
Yes.
Why we don't strip the entire vein?
Like risk to injury to saphenous nerves.
So very good. Okay, below knee there is it's very closely. Okay, in both the vein and the nerve go very closely. So there is a chance of injuring the, when you are like removing the vein, there is chance of injuring the saphenous nerve also, can cause saphenous neuralgia. It's very, very irritating. Okay. So we avoid that. So we just put another incision just below the knee and bring out the strip, okay, and then strip the entire vein. Clear?
Yes.
Okay, there are any perforators are there. We just ligate the perforators also.
Yes.
Okay, this is the surgery. Any other newer techniques, you know?
So thermal ablation we can do.
Okay, okay, radio frequency ablation we can do. Then
laser.
what is EVLA?
EVLA, sir, endovascular laser ablation.
Very good. Okay, very good. Then anything else?
Then radio frequency ablation.
Okay.
Then sclerotherapy.
Okay, almost done. Okay, now what are the complications of surgery?
So first of all, like nerve injury, we have said. Nerve injury. Nerve injury, sir. Saphenous nerve injury.
Yeah, in case of long saphenous nerve, it is saphenous nerve injury, whereas short saphenous nerve, we can injure
sural nerves.
Sural nerve, okay, or even the lower common peroneal also. Okay.
Yes.
Okay. Then that's the one is intraoperatively you can injure the nerves.
Yes,
okay.
Then infection.
Okay, that can cause bleeding and hematoma intraoperatively when you are stripping the vein. If you're not ligated all the tributaries properly, that can lead to severe bleeding and can cause hematoma. Okay, then it can get secondarily infected. So infection also very common.
Yes,
infection also. Okay, then anything else?
No, so failure of surgery.
Oh, yes, that's called recurrence. Okay, there's nothing of failure of surgery. There is a recurrence. Okay, so these four are the common this thing. Okay, complications. Yeah. Okay, next slide.
Some pictures are there. So
yeah, I'll just explain. Okay, these are the some of surgeries done by us. For the interest of the viewers, we have put some of these images. See, this is a case of perforator ligation. We had marked the perforator beforehand, before the surgery, and just we give a small stab incision over that perforator, and we have ligated and we have cut the perforator. Okay, this is how, and we close the defect. This is how we do the perforator ligation, subfacial ligation of the perforators. Clear? Next slide. Okay, this is a first one is ulcer. Okay, this is a venous ulcer is there. Okay, see, almost like oval to circular. Can you describe this ulcer, Mr. KJ?
Yes, sir.
Yeah.
Sir, oval shape ulcer.
Oval to a circular, almost it's a circular ulcer. Okay.
Yes, sir. Present in the medial side of lower leg.
Okay.
And irregular margin.
No, it's regular margin. It's almost circular. You're telling only circular, then you're telling irregular margin. Okay.
So regular margin.
Well defined regular margins. Okay.
Well defined regular margins. This one granulation tissue you can see on the floor. And sloping
edges. Very good. Then
margin edge.
Surrounding skin.
Okay. Surrounding skin, some whitish area I can see, sir.
No, not really. That's a light glare of light. Okay. Yes. Surroundings area appears almost normal. Appears normal. Okay.
Yes.
Okay. So it's like looks like any acute ulcer. Okay. Not very long-standing ulcer. So no secondary skin changes and all present. Okay.
Yes.
So we have debrided the ulcer now, and we can do skin grafting for that. Along with the varicose vein surgery, we can do the skin grafting also for this ulcer. Okay. So what we are doing in the other photo there. Can you see? What is that?
Yes, I guess saphenofemoral ligation.
Yeah, saphenofemoral flush ligation. Okay. That is a great. Next photo you have?
Yes.
Okay. See, can you see that what I am holding with the artery forceps? It's one of the tributaries of the great saphenous vein. Yes. Can you see? Can you see my marking there? Arrow mark. Can you see?
No, sir.
What I'm okay, you can't see the arrow mark. Okay, the whitish. Yeah, that is the tributaries. The below that is the great saphenous vein. It is joining from the medial. Medially it's coming and joining the femoral vein above. Okay. What is a big vein? Is the great saphenous vein. It's small tributary. What I'm holding is the one of the tributaries, okay, of the GSV. We have to ligate that first, and then at the junction of the GSV and femoral vein, we have to again ligate. Is it clear? See,
Yes,
again below that, above that, can you see a blue marking there? Blue in the marker we have written on the skin.
this one.
Yeah, that is the femoral vein. We have marked beforehand in the scan. See,
Yes.
almost great saphenous vein comes and joins that vein.
Okay.
Can you imagine? Can you make out that clearly?
Yes, sir.
Okay.
Yes.
See what's on the left hand side. What's that photo? See, so many marks are there. What are those?
Perforator, I guess.
Yeah. Okay. This is a all we did for so many perforator incompetences were there. Okay. Not so many were not perforators. Okay. That I did because so many locally enlarged veins were there. So okay, I just because lower leg we can't strip the vein, right? Just for the cosmetic purpose, I had to disconnect the veins. Okay, so multiple stab wounds I have given and cut the ligated the vein and cut. That's why we can see so many scar marks over there. Clear?
Okay. Yes, sir.
Can you see the lower the dermal flares and all? Can you the lower down in the right leg?
Yes.
Yeah, that is the dermal flares. Can you see small veins? So many veins. What's the dermal flare? What is a reticular vein? What is what is this? Thready veins or spider veins.
Reticular vein is less than 1 mm. Then telangiectasia 1 to 3 mm size.
Ulta, you are telling ulta.
Sorry.
Telangiectasia or spider is the thready veins are the less than 1 mm.
Yes.
1 to 3 mm is the reticular veins. More than 3 mm is the varicose veins. Okay.
Yes.
Clear? Next,
Yes.
any more photos?
Yes, sir.
Okay, this again. See that one of the tributaries being ligated there. Next one is that's the stripper.
Yes,
the entire photo I don't have, and it's a vein. Along with that, vein has been stripped out. Can you see the entire vein has come out?
Yes.
Okay, that's the stripper and the vein along with that. Any more photos?
No, sir.
Okay, fine. So you almost you answered almost everything. Okay, Jay, very well prepared.
Yes.
What's very important for you? This varicose vein is important for both theory as well as practicals. In theory, they can ask you this theories, hypothesis. I mentioned in the beginning itself. Okay.
Yes, white cell
and about the complications, you can get some questions on the complications of the varicose veins. Okay, and in the practicals, definitely you'll get invariably you'll get one varicose vein case. Okay, if not varicose vein, as a short case, you'll get an ulcer case. Most probably varicose ulcer. That will be definitely there. So be well prepared for that. And in that, you should know the mainly course of the veins. They can simply ask you on anatomy of the vein, and they can okay course of the veins we should know, and other things, most of things we have already discussed. The symptoms, signs. Most important in varicose veins is the special tests.
Yes, sir.
You have done all the almost special tests which you could not do. Don't try to bluff the examiners. Just admit that I have not done or I could not do. Okay, nothing wrong in that. Okay, admitting that. And after that, don't forget to do the other examinations, like other than the varicose vein test. We have to do the check for the lymph nodes. The ulcer is there, means ulcer in detail, lymph nodes, neurovascular deficiencies, okay, and the other limb and joints, adjacent joints. Okay, all those things should be bones also. For periostitis and all, I already told you. All these things should be examined, not just the varicose veins as such. Then coming to the in the Viva, Viva, they can ask you the operative procedures. In that, you can tell this Trendelenburg procedure. In that, they can ask you what are the complications. Okay, what are the other surgeries you know. Okay, all those things can be asked. So this will varicose veins. If you study properly in final year, you will get minimum of how much I say in practical. If it comes, it's for long 100 marks, you can get around 80 marks, and 10 marks of theory, 90 marks, and Viva 5 marks, almost 95 marks in your hands today itself. KJ?
Yes.
95 marks of a final year already there in your hands. Okay, if you read varicose veins properly.
Yes.
Okay, are we
Yes.
good?
Yes,
Any
sir.
doubts? Any doubts?
Yes.
Please, members, any doubts? Please ask. Larry, you have any doubt? Yeah, CEAP. Don't forget to write the diagnosis in under 6 headings.
Yes.
Okay, and also mention the CEAP classification. Very important.